I'm going to ask a few questions, and of course the speakers will be up here if you have any. But I want to start with you, Dr. Schechter. So what I hear a lot and what happened with our own daughter was, and especially in the early days when she was having, like when she was 2, 3, 4, 5, she was having hundreds of seizures a day. And sometimes she would seize after eating and vomit, and then she would inhale that. Or one time she seized in the sandbox and inhaled the sand. Or she would seize and you could hear it. Like you could hear the saliva kind of going in, and then now everything's rattling. Is there anything a family can do today if that is their experience, right? Like what would you do if that was like your kid or your patient, if that was sort of a common scenario where every month or every 2 months you had some situation like that might be aspiration, it might be not when you went to the hospital and they did the x-rays, it was. Is there anything that can be done now to sort of mitigate that?
Well, I think as I said, I don't know that we have a way of actually preventing large episodes of aspiration when they occur in the context of a seizure or something like that. But there are underlying issues that are potentially there that might make it worse. And that's I think, maybe the point for a situation as you described. So did your daughter have a tendency to, again, allow things to go down the wrong way when swallowing, even when well? Did you look?
We didn't look, but like she didn't have like swallowing or speech or anything, but we didn't look, you're right.
But so this is the point. I think that, and it doesn't necessarily mean that every single person has to get one of these special x-rays, but you should potentially at least be evaluated by somebody who is sensitive to those sorts of issues, by a physician who's sensitive to those sorts of issues.
Like you, a pulmonologist.
Well,
Maybe.
That would be a good example, yes. So I think that, or speech therapists, because the speech therapy people are the ones, if you're involved with sort of general rehab programs with physical therapy and occupational therapy, and then there's a speech therapist there as well. I mean, having them take a look as well would be a possibility. Possibility number two, or concern number two is, are these recurring episodes causing some underlying chronic damage that make it even worse when she does actually aspirate? And so looking for that bronchiectasis that I'm talking about, is important. And then in the context of having an episode, are there things that you can do acutely to help her to mobilize the secretions a little bit better, depending upon whether there are anything that's in the way? So I think that, again, I think a pulmonologist who might be sensitive to these sorts of issues would at least be able to explore those possibilities to see if there's some way to mitigate the severity of the problem when it occurs, even if you can't prevent the actual aspiration episode.
Great. I mean, the good news was that she sort of outgrew it. It was about 4 years, and she was getting pneumonia like 7, 8 times a year. They finally just would send us home with antibiotics. And when we would call the neurologist, he would trigger the yes, take them, right? Because this kept happening. But then, but she had explosive onset, and so thank you. I have another question for you in just a second, but for all three of you, actually. My next question is for Dr. Gupta. So one of the theories that's just emerged recently, so we've always known that the LGS, we talk about the area of the brain that's on fire in LGS, it actually overlaps with the slow wave sleep circuit. And so one of the things that our scientists are thinking right now is LGS co-opting the sleep circuit? And so there's a lot of interest in this. And so my question for you is, if you were going to redesign the survey, and there was a foundation, for example, that had a platform, have platform need surveys, and you have surveys and need platform, and all under IRB to caregivers, like how would you design it? Like maybe would you put wearables on a caregiver and design some inclusion-exclusion criteria and do that, or are there certain surveys that you would put out? But how would you design that next study in, for example, our LGS core database that we're shamelessly promoting?
This is an excellent question. I will take a moment to think about it. I've taken a moment. So I talked about sleep surveys, and one interesting thing about the sleep surveys, and I wonder if that's why my results about sleep and quality of life were kind of unusual or surprising, is that these surveys weren't designed for people with conditions such as Lennox-Gastaut syndrome. They were designed for typically developing children. The way, different kids sleep in different ways, and the sleep environment is different in different conditions. So I think the first thing I would want to do is have a survey that is more specific for people with Lennox-Gastaut syndrome. I would also like to survey caregiver and child sleep as well. I think that's super interesting. I didn't mention this in my introductory slide, but I'm a sleep physician for both children and adults. So it's a interest of mine clinically to see how sleep develops over the lifespan, but also I do have patients where I take care of both the child and adult. And I oftentimes will hear, say in my pediatric clinic, the parent says, I haven't slept for 3 years, I haven't slept for months, or, they're tearful in my clinic. I know you guys probably can tell I can't take myself away from tearful parents, and that gets me in trouble sometimes. But, it's true. If you're chronically sleep deprived, it's awful and it's exhausting. And I think we don't study caregiver sleep enough, so I definitely would want to have that as a component. And then, cherry on top, if I could put a wearable on both the child and the parent, I would do that as well.
That is fantastic. I think we should do that study. So I actually have the same question for both of you, but I put poor Gita on the spot. And so you guys can have a second to think about, because I do have a question for you too, Babitha, and then I'll come back. But go ahead. Yeah. Of course, please add.
Earlier. So recently, actually at AES, we're going to be presenting, hopefully, a poster that looks at the prevalence of sleep spindles in our children with LGS. So the way that, Geeta and we know that our children are falling asleep is by changes on their EEG pattern. And when they enter, they go through stage 1 of sleep and then stage 2. And as they go into stage 2, there's a specific pattern on EEG that looks like these very cute little spindle squiggly lines that are called sleep spindles. And then they transition into slow wave sleep. So one of the projects that we're actually working on right now is looking at how the relationship between all of those sparks that are going off in our loved ones' brains that we can see on EEG and the prevalence of sleep spindles. And so we actually just finished that preliminary data collection and evaluation and found that the results are actually very significant, where we see whenever we see a high number of spiking or those sparking going off in the brain, we see an incrementally low number of sleep spindles, which is consistent with the findings that we're noticing with the disrupted sleep. But this just adds an extra layer of objective data to that.
I cannot wait to see that. The researchers who helped to describe the LGS network posed a hypothesis, which is completely theoretical right now, but is slow spike in wave somehow the pathogenic or pathological expression of slow wave sleep, and is GPFA hijacking the spindle, and it's the pathological expression of a spindle. And so it's important for us to know that, because we know a lot about the sleep circuits. We know nothing about the LGS circuit. We know very little about the LGS circuit. So anyway, so they're testing that and they're drooling over it as the scientists that they are. But I do want to ask Babitha one question, and then I want to come back to you, Dr. Schechter, and then ask you, Babitha, as well, how you might design a study in our core study where we can do caregiver surveys under IRB and ask some questions, like for lungs, it's probably some basic questions about who has what, because we don't know much, but what would you ask? And then I want to ask for status. But before I do that, I'll let you have a chance to think. But Babitha, I have one question for you, and then I think we have one question from the audience too, and then I'm sure you guys will get bombarded. But if we had our families say that they want to really go after the sick day plan, what should they do right now? What should they do next? And if they need to talk to their doctor, what should they say?
To create a sick day plan? Was that the question? Yeah.
Yes, for a sick day plan.
Yeah. So I think in my clinic, we frequently use a sick day plan, and I think it's a great idea and highly encourage all of you to discuss it with your neurologist or epileptologist the upcoming visit. So number one is to understand when to implement the sick day plan. I think our LGS families are amazing, and they often send me a message on my chart saying that, yes, I notice a slight uptick in frequency of the seizures, but I have a feeling we're just heading into a really bad weekend, right? And so number one is to understand when the sick day plan should be implemented. Should it be if we're noticing an uptick in seizures at an X%, right? Or an X number increase, in, especially in which type of seizures? Or is it that the seizures are lasting just a little bit, just a smidge longer every single time with shorter periods of recovery in between? And then establish what our actual plan is going to be. So oftentimes when we, in my clinic, we tend to use clonazepam bridges, especially as we're going through infective periods. And my families know exactly when they should implement that clonazepam bridge. And this way they're not left stranded on a long, holiday weekend and are not waiting for a call back from the on-call neurologist because they already know what the plan is. They have the prescriptions on hand, and they know that they should activate it. So to summarize, I would say, number one, definitely bring it up with your neurologist or epileptologist. Number two, understand when to discuss with them when we would want to implement this, what the signs are that we should look for. And number three, discuss which medication and for how long we would want to use this for.
Wonderful. Dr. Schechter, would you mind answering that question? Do I need to repeat it, or you got it? One more time. Okay, so we have this thing called the LGS Core Study, and it's caregiver enter survey data under IRBs. And we essentially have a platform where we could administer any survey under inclusion-exclusion criteria to our more than 8,000 member community. Families can enroll and answer these surveys, the caregivers. And so if you wanted to explore lung issues in a community like ours where you know a lot about lung things, and we're just beginning to learn. What kind of a study what kind of questions would you ask? What kind of a study would you do to try to help inform this community? The goal of the survey is to inform these families about what's out there and what they might want to look at by accumulating the numbers of how often these things are happening or what the issues are. So that's sort of the goal, is to get information back to families that might help them.
Yeah, so I guess the main thing would be just to quantitate the number of respiratory events that each individual experiences. And some of them may be severe enough to require hospitalization or even an ICU stay. And some of them might be milder that would just lead to a visit to the doctor's office or to the maybe urgent care, maybe administration of an oral antibiotic. It would be of some interest to me. I didn't really get into this in a lot of detail, but asthma is an interesting diagnosis, which is often underdiagnosed and also overdiagnosed. But so the question, though, would be is how many people with LGS have albuterol that's being prescribed for them or other sorts of asthma medications. I think there could potentially be questions regarding any other explorations that have been made in terms of some of the underlying issues that I talked about. How many people have actually had a so-called modified barium swallow? How many of them are being treated for reflux? How many of them have had a CT scan to evaluate for bronchiectasis?
That's fantastic. Thank you. Totally stealing that, we might call you.
Would I be able to add something to your idea? So I think that all of what Dr. Schechter said, plus, are the pneumonias in the same spot? Are they in different spots, or are they typically in the same spot? How often did the child need antibiotics, I think is interesting. I know that that can be sometimes oftentimes not a perfect way of distinguishing between bacterial pneumonia and a viral pneumonia or just inflammation, but it can be helpful. And then did they need steroids as well? I think that would also be helpful.
Although I wouldn't use the word need, I would use the word prescribed.
Fantastic. And Babitha, how about a survey for status, I would focus on status and clusters.
Sure. So I think a lot of times when thinking about research ideas and designs, one of the ways that I like to approach it is thinking about how we can bring it to families, right? How it affects patient care. So working backwards from there, I think a key question is how we can prevent ER visits, ICU utilizations, and being that status is a common reason for going to the ER and needing to go to the ICU. So with that in mind, I think the way that I would probably structure this idea would be to look at what actually was the inciting trigger for status epilepticus, and actually hearing it from you guys directly would be very helpful. Knowing what the rescue medications were that were used, what the doses were, and what the current weight of our LGS loved ones are actually helpful. A part of this is actually stemming from additional data that I did not present today, but additional work looking at the LGS status population that we looked at, and some of the graphs that I had shown had demonstrated that around 90%, 92% of our LGS kiddos had needed to go to the ICU, and 50% of our patients of our LGS kiddos needed to be intubated. So this is a very I don't need to say this to you guys, but this is a very fragile yet powerful cohort. You guys are all LGS warriors, but I think we can do a lot to try to prevent the ER visits, prevent the ICU utilizations, and so getting this data about what triggered the status, what the dose of the rescue medication were, and when the rescue medication was administered with respect to when we think the seizure started, or the cluster of seizures started, would also be helpful in helping optimize those sick day plans to prevent ICU and ER visits.
Excellent. That was fantastic. I totally hogged the Q&A period. I'm so sorry. Marcelo.
Sorry, Tracy, but Miri has an important question. So I had 26 questions, but given the time, I will just ask one. Miri has an important question about saliva, and I know that a lot of parents will be identified with this question. So we have a lot of issues, and it's well known that we have a lot of issues with drooling, with excessive saliva production, right? With choking with saliva, and I'm pretty sure that that kind of like helps a lot with choking and aspiration and those things. So in one of our visits to our ENT doctor in Children's Hospital in DC, she recommended ipratropium. So in that way, she says that they were using it with LGS patients, and to reduce, it's an anticholinergic, is to reduce the production of mucus, and in her words, that helps in patients, with excessive salivation and choking. So I wanted to know if, especially you, Dr. Schechter, have any opinion about it, and if you are not in agreement with that medication, are there any other medications or therapies that we can use to reduce the drooling and excessive salivation for our kids? Long question, sorry.
So yes, there are a number of approaches. In terms of specifically the use of ipratropium, so there are these medications that we call anticholinergic, and they do decrease some of the secretions in various places. So ipratropium is an anticholinergic that you can inhale. I don't know exactly how it would specifically impact on saliva if you're inhaling it, because you're bypassing the salivary glands, but it will potentially decrease the secretions within the airway. Now, sometimes that can be a problem. Sometimes it can make it worse if they're thick and harder to clear. But by and large, it's a reasonably good strategy, and it's a medication that is used in a variety of different contexts, sometimes in asthma, and sometimes in people who have some increased secretions. in the airway. So I think it's something that is, if it's being recommended, I think it's certainly worth a try. There are a number of other approaches for decreasing the salivary secretions, which include medications. There are some so-called anticholinergic medications that can be used to decrease these secretions. Glycopyrrolate, which you may or may not be aware of, or I'm sure many people in the audience will have heard of. And then there are some physical measures that can be used to decrease secretions, including Botox injections, including some, I'm blocking on the word, but there can actually be surgical removal of the salivary glands, and there can be other medications that are injected into the salivary glands to stop their secretions. So there's a number of things that can be done about it, and there's a little bit of controversy about the role of aspiration of saliva in terms of developing pneumonia. There are some people who actually believe that that's an important consideration. I'm not necessarily one of them, but I think that that aspiration of salivary secretions is certainly something that is irksome and that can cause chronic cough, and can cause a number of difficulties. So it's a common problem in people who have different sorts of neurologic issues.
Great question, thank you. One last question right here, right behind you, Kaylee, and then I just have to say two things, and then we can go to lunch.
Just a quick comment, doctor. There is a liquid available for glycopyrrolate, which I developed it in 2002 or 2003. So you could apply the liquid in the mouth, so it won't go down, and you could reduce the secretion. We developed it for cerebral palsy.
Great, thank you, thank you. Well, you guys have been just a fantastic panel. It's like extreme paneling when you've got a whole room of LGSers who are like elephants. Once one sounds off, they all come running to sound off. But you know, in our world, this is pretty normal for us, so we just really appreciate you guys accepting that this is their conference and being such good doctors.